Good morning, everyone. We're going to get started in a couple minutes. Thanks for being on the call early today.
Good morning. Good morning. And welcome to everybody. Thank you for joining today. All right, so thank you everybody for joining. Good morning and welcome to this webinar presentation by Dr. Carolyn Johnson of the Philadelphia Department of Public Health on the Philadelphia COVID-19 vaccination plan. Given just the number of individuals that will be taking part in this meeting today, we'll ask. I'm going to ask that questions and comments be posted in the chat box for the participants and that need to be answered, and we will address those, as many of those as possible, towards the end of the session. Um, the intent is to gather those questions and develop additional responses to them in the form of an FAQ document. I'll ask folks to hold their comments until after Dr. Johnson has completed her presentation. Um, uh, so Dr. Johnson, given the amount of time and the number of the information that has to be shared, I'm going to turn it over to you. I understand that Doctor, we're still waiting for Dr. Johnson to join. We'll just while she's, and I appreciated people's flexibility with this. I'll just invite anybody with questions to or thoughts to post them in the chat box so that we use that function to communicate. Thank you. We'll give it a couple more minutes for Dr. Johnson to join us. Still waiting for her to join. All right, welcome, Dr. Johnson. Thank you for joining. We've got 230 people on the call and more joining by the minute. I'm going to turn it over to you now.
Okay, so this is testing. I'm having a lot of issues with connection and you not being able to hear me. Can we first do a test? Can you confirm that you're hearing me?
Yes.
Okay, do you see me?
Yes.
Okay. All right, so I'm going to go ahead and proceed then. And I assume I do not have control of the slide, so I'm going to instruct someone to advance them. Okay, so advance to the next slide, please. Okay, so I'm just going to cover a few things about COVID-19 vaccines and then give you an idea of what the plans are for behavioral health related facilities. You may already know some of this information, but there are now 2 vaccines that have been authorized by the FDA to be used under an emergency use authorization. They've completed phase 3 trials. And the FDA's status of emergency use authorization is not really a shortcut, it's just expedited. So what that means is that the clinical trials and the work done on these vaccines was done in a very expedited fashion, but it was not shortcutted. Next slide. Okay, so the 2 vaccines you probably read in the newspapers, it's a Pfizer product, and then there's the Mrna product that was just approved over the weekend. We in Philadelphia have received some of the Pfizer product. We have not yet received any of the Mrna product, although we're expecting to get it this week. Both the vaccines have been tested widely in tens of thousands of adults, and the population it was tested in was quite diverse as far as age, race, ethnicity. The clinical trials show that the vaccines are both safe and effective at preventing COVID-19, but there's some things we don't know. For example, we don't know how long the immunity that's induced by the vaccines will last. Next slide. This is just a snapshot of the clinical trials done with both vaccines. Again, large trials. These were placebo-controlled trials. So half of the people that enrolled got the real vaccine and half of them got placebo. And then you measure what the outcome is in the people receiving vaccine versus those who got placebo. Next slide. These vaccines are made with a new technology they're called mRNA vaccines or messenger RNA vaccines. Now, when I say new technology, the technology's been in development for 15 years, so that's not new, but applying it to the COVID-19 is new. And these types of vaccines have been shown to be really very safe, but they are reactogenic, which means that when you get the vaccine, you can expect to have some localized symptoms. Some arm pain, sometimes some headache and myalgias or muscle aches the day after, but no serious side effects. There are no increased risk of death, no increased risk of severe cardiac events or other events. The one thing that we have observed is that there is probably some component in the Pfizer product that has caused some allergic reactions. So we are kind of watching for allergic reaction should they occur after these vaccines. The interpretation of all of the local symptoms, the tenderness at the arm and the headaches and muscle aches that may occur after the vaccination is kind of interpreted to mean that the vaccine is working. Means that you're producing interferons and interleukins, which is the body's response to vaccines. Again, there were no significant safety concerns that were identified in the clinical trials. And patients who received these vaccines were observed for 8 weeks after the clinical trials, after they received both doses of the vaccine. And with other vaccines, all of the adverse events that are associated with the vaccines occur within 6 weeks. So an 8-week observation period seemed to be pretty reasonable to assure the safety. Next slide. Okay, a few facts about these COVID mRNA vaccines is one, there's no live virus in there. There's no chance of you getting COVID-19 from receiving this vaccine. I already mentioned that there's some normal side effects, sore arm, maybe some low-grade fever, maybe some achiness. These side effects are signs that the body's building immunity. And after you get the vaccine, you need 2 doses of it, and it will still take 2 weeks after the second dose to actually have immunity. So from the time you start the process to the time you can finish the process, it's about 5 to 6 weeks before you will be immune. Next slide. Couple comments about testing. If you get vaccinated, you do not get a false positive test for having the infection. So the vaccine does not produce the DNA that's detected or the RNA that's detected with a test for COVID. You could get positive antibody in your bloodstream. So when you're vaccinated, you may end up having a positive antibody test in your bloodstream, but you will not ever get a positive test on a nasal swab from getting vaccinated. Next slide. This slide is really about the issue of if people who have previously had SARS-CoV-2, which is the cause of COVID-19, should they be vaccinated? And the answer to that is yes, because when you have natural occurring COVID-19, the immunity you develop may not be long lasting. We don't actually know how long it lasts and who will have any kind of immunity versus natural infection. So the current recommendations are, yes, even if you've had SARS-CoV-2 in the past, you should get vaccinated with the COVID vaccine. However, because of the shortages in vaccine supply right now, we're suggesting that people who have had infection within the last 90 days defer vaccination until after 90 days. Next slide. Okay, now I'm going to just switch gears a little bit and talk about the vaccination plan. The city has developed a plan for distribution of COVID vaccine across the population. We've had multiple versions of this plan, and we're currently on our 3rd version. We have a community-based vaccine advisory committee that reviews the plan and advises on the strategies of priority groups and how to distribute the vaccine. Right now, the executive summary for this plan is on the city website, phila.gov/COVID. And the full plan will be posted soon, but there's still some changes that are being made. So we're gonna wait till we get those changes up. Next slide. So you probably heard about the prioritization schemes, and we essentially, the CDC is describing the distribution program as phase 1, phase 2, and phase 3. And phase 1 is the one that's probably got most people kind of confused and concerned. Phase 1 is when vaccine supply is very short, as it is right now, very limited number of doses coming into the city, and we have to prioritize who those doses are going to. And I'll go back to that in a second. Phase 2 is the vaccine supply is really starts to increase, and we are expanding out the number of people we offer it to. And then phase 3 is when vaccine is going to be available for the general public and upon any request. So let's go back to phase 1. Phase 1 has been divided into 1A, 1B, and 1C, and you'll see different descriptions of who falls into each of those categories. but in very broad strokes, the way we're looking at this, phase 1A is healthcare workers, long-term care, residents and staff. Phase 1B are essential workforce who interact with the public and are exposed to COVID every day. And then phase 3 are people who are residents in congregate settings or are somehow at risk because of being grouped together, and will be some persons with chronic underlying diseases. So that's kind of a broad description, 1A, 1B, and 1C. Now, most of you are going to fall into the 1A. Early on, Philadelphia Health Department had decided that the behavioral health providers would be classed under healthcare providers if they're public facing. So this does not include purely administrative staff who never interact with the public, not the public, but with your patients. But this does include anyone who can be expected to be interacting with your patients. That can be, clinicians, nurses, pharmacists. It could be people who do facilities management, people, social workers who may be counseling them. If they're in primary contact with any kind of patient in the facility, they're going to be called healthcare workers and are eligible under phase 1A. Now, remember, phase 1A, there are about 125,000 people in Philadelphia who fit that definition. And so far, we've gotten 13,000 doses of vaccine. So it's even difficult to push out to get enough vaccine to push it to everyone in 1A. But that is an overview of what the distribution strategy looks like. Next slide. I think this is kind of redundant of what I just said. Next slide. Okay, so 1A. So how are we doing, healthcare workers? And what can you expect to see as available access for vaccines? Well, the first priority, and this is basically all that's been done so far because of the limited amount of vaccine, is to get this to hospitals and occupational health. And they're using this in their emergency rooms, in their ICUs, and in their pulmonary units, where the staff there have continuous ongoing exposure to COVID-infected people. So we are really focused now on hospitals and their occupational health units are the ones that are handling distribution. We also are launching a few vaccination clinics where we are accepting appointment-based people to come in and be vaccinated if they are high risk in the community. For example, the staff who are all doing the testing in the community, you've probably all heard of Philly Fighting COVID and the Black Doctors Consortium Against COVID. They are all actively testing in the community. They're extremely high risk. So we're bringing them in and getting them vaccinated. We are now also building partnerships with other healthcare providers to get them vaccine so we can reach the full group of 1A healthcare workers. And those partnerships are mostly with pharmacies, with urgent cares, with some of the FQHCs or the federally qualified health centers. And that network will build out over time. But those are the ones that we expect to launch first are going to be the pharmacies, the urgent cares, and the FQHCs. Next slide. I'll skip this. This is about a long-term care program and nursing homes. Next slide. Yeah. Okay, so I think this is the last one. It's really the questions that you're going to have, or you probably asked, is how do you all fit into this, and what can you expect? So let's divide this into staff and then into patients. So the staff, if you're patient-facing or public-facing, you're a healthcare worker and you're eligible under phase 1A. And what that's going to mean is when we get vaccine into the hands of those pharmacies and urgent cares, we will notify you. And I imagine we will go through DBHIDS to get these notifications to you, but we will tell you that, you know, the Rite Aid or Vibe or whoever it's going to be is open for you to schedule appointments. Now, all of the vaccination opportunities are going to be appointment based because we can't have people queuing up. We're still in a situation of a pandemic. We need everyone to remain socially distanced and masked. So all of the vaccination opportunities now and in the immediate future are all going to be appointment driven. So you, the healthcare workers in the behavioral health facilities, are going to be notified that you can schedule appointments at, you know, Rite Aid or Vibe. You will likely have to approve your employment opportunity or where you're working to make those appointments, because we're going to have some control over this. We can't have the invitations being sent to, you know, relatives and things like that, because then there won't be any opportunity for the true healthcare workers to be vaccinated. But you will be notified when there is an opportunity. It may be rolling, meaning we may not be able to open the door for every single facility at the same time because the numbers may be too large, and we may choose to do one group 1 week and another group the next week. We're going to have to see how much interest and need there is in the population. How about your patients? So for places that have residents or inpatients, they would fall under the congregate setting. So that would be 1C. Your patients would be up for vaccination when we get to the 1C grouping. And we'd have to figure out how to get that done. Probably if you have your own clinical staff, we could deliver vaccine to them to administer, or the facility could contract with a private provider, a vaccine provider, a pharmacy, to come in and do the immunizations for you. For those of you who are treating outpatients, for the most part, they're not going to be available to be immunized until phase 3 under the general public. There may be some situations where they're seniors or they're chronic disease and they'll be eligible earlier. But I do not think that we're going to look to the facilities, the behavioral health facilities, to be immunizing their own patients. It's more likely that you will be referring your patients into other venues to be vaccinated. And with the exception of the facilities that have residential patients. And the last thing I put on there, you know, why is this so complicated? You know, is why can't I just give vaccine to my staff or to my patients? It is very complicated to set up this network. And the key things are, the first way that you become a vaccine provider is you sign a legal agreement with the CDC that restricts how you're going to use the vaccine and what your requirements are. That's not a big limitation, but it's something that the provider enters into a formal agreement with the federal agency to become a vaccine provider. The second thing is, if a facility wants to handle their own vaccine, they have to be able to meet storage and handling requirements. You've probably been reading or heard in the news about this ultra cold storage, which the current vaccine from Pfizer has to be stored at -80 degrees. That's not the kind of freezer that you all have in your facilities or you even have any kind of access to. So even if you wanted to immunize, you could not handle the vaccine. The vaccine's lifespan is only 6 hours after it's out of the freezer. So it's very tricky. And it's not something that can be done in your facilities very easily. Now, some of the newer vaccines that are coming out will be easier to handle and may just require refrigeration. And those of you who have clinical staff who are licensed to do vaccination, and there's a pretty broad network of them, we would, you could actually meet the storage and handling requirements, but not with any vaccine that we have now. And then the final one, which is probably the hardest of all for y'all to accomplish, is that these doses of vaccine have got to be reported to the federal government, specifically to the CDC, every 24 hours. So we need to collect data on all of the individuals who are receiving the vaccine, and then it has to filter through to the CDC. The names don't go to the CDC, but they're counting each of these individual events so that they can have an idea of how much vaccine is being given and if there's side effects. So this requires that electronic medical records develop an interface with the local immunization registry that's known as Filovax, and then we capture all the administration data and pass that through to the CDC. So these last things, it's not impossible for some of you to become vaccine providers yourself, but it is rather complicated. And that last one, to set up the information technology for these linkages between electronic medical records and the immunization registry are really rather sophisticated, and I don't know how reasonable it is to have those expectations of you, but it is a requirement. And then I think the last slide is there's just a list of resources that are on the websites right now. The General City COVID website is, there's a vaccines tab there with general information. It is not targeted to healthcare providers. This is more public info. The second one, the Philadelphia Department of Public Health Filovax, that link is much more technical and is targeting to healthcare providers, and it's where you would find information about how to access for your own for yourself, for your healthcare providers in your network, or for the patients. And then I just listed 2 other sites where there's general information about COVID and COVID vaccine. This field, this vaccine distribution is moving extremely fast right now. There are changes every day, and it's somewhat difficult to push out as much information as we'd like to. We'll get better at that over time. But that's really the status. And I'll just reiterate, you all are eligible for vaccine. The staff who are public or patient facing are eligible to receive COVID-19 vaccine in the phase 1A that we are currently in. The problem is the supplies have not allowed us to get outside of hospital networks yet. I would estimate that we will start having vaccine in the community for y'all to access either the week of the 28th or the week of January, I guess it's the 4th. So we're not talking a long time away. We believe we're going to have vaccine, and enough of the vaccine that doesn't require the ultra cold storage available that we'll be able to announce to you that you can access vaccine. And I think I will end it there. So if there are, let me see, it's 11:30. So I have time to answer any kind of, more specific questions or clarify things. If anyone would like to moderate this. And
thank you, Dr. Johnson. Thank you for your presentation. There are a number of questions already posted in the chat, and I'll just walk through them one by one to the extent that we have the time. We'll cover all of them as possible. If we can't, then we'll collect them into an FAQ document and respond to them after the fact.
Sure.
Thank you. The first question is from the net. How will vaccination with substance abuse intake programs, how will it work? It sounds like the net access point serves approximately 350 clients who are high risk. What would be the plan to give the vaccination to the staff?
So this is for staff. Is this question specifically about staff?
That is correct.
Okay, so this is the staff will be notified that vaccine is available in one of the sort of public access points, which is probably going to be a pharmacy or an urgent care. No one is coming to you to vaccinate your staff.
Mhm.
So this is, you can either recommend that your staff go to one of these pharmacies, or you could conceivably contract one of the pharmacies to come on site, and we could give them the vaccine to administer. But I think the important thing to know is this is not a health department initiative where we're just going from clinic to clinic vaccinating people. We make the vaccine available to people who will administer it, but you will be notified when it's available at the pharmacy.
Okay. Thank you. Second question, should staff at a particular site be vaccinated several days apart so that all the staff will not incur this day one effects of the vaccine at the same time?
Yes, that's a very good question. It is something that the CDC has made recommendations about because of the reactogenicity or side effects basically from the vaccine, the sore arms, sometimes some low-grade fever, some achiness. There have been concerns that if you vaccinate everyone in a facility on the same day, that some of them might be out sick the next day and you don't want to deplete your staff resources. So there have been recommendations of cycling through staff. So maybe you do, half of them one week and then the other half the next week, or, different days. I really think that's a judgment issue for the facility. When I've been talking to the hospitals about their experiences, and we have not seen a lot of staff absences after being vaccinated, but I think it's a possibility that there will be an increase. So, take that in mind when you plan, when you refer your staff out for vaccine.
Thank you, Dr. Johnson. The third question here is, how will individuals in group homes with intellectual disabilities get the vaccine? What is the priority?
That one is very, I think it's still being worked out is the answer. So there is a plan right now that involves, it's a federalized plan where the CDC is contracted with CVS and Walgreens, I believe, to go into nursing homes and to deal with vaccinations on site through so the pharmacies actually will be administering the vaccines to the staff and to the residents in nursing homes. When they finish the nursing homes, they're moving on to the assisted living facilities. And I would believe that they are going to move on and start doing group homes, but that's not been stated outright yet. So I am kind of assuming that the group homes are not going to be as mobile to allow them to be taken into a site, and we will have to make arrangements for sending people in to vaccinate those clients. But I think there are so many group homes and the resources are so limited that we don't really know how we're going to do that yet. It may be that we send mobile teams out to vaccinate them. It may be that the federal government asks the pharmacies to also run a mobile strategy to go in and vaccinate them. So I would just say that there's more to be worked out on that issue. I do not think the group homes are going to be eligible for a vaccine for 6 to 8 weeks is probably when we're talking about getting them up and running. So we still have a little bit of time to figure that out.
Thank you, Dr. Johnson. And to your earlier point, I mean, this speaks to your earlier point that much of this is still rapidly evolving and a lot of planning is still underway.
Mm-hmm.
So, okay. The next question, if you have I think this is a good one. If you have a known history of allergic reactions, what would be the best approach to re-emerge back to normal levels of activities if you do not get vaccinated? Are you at greater risk of exposure?
So the alert allergy issue is probably the only contraindication or concern that we have about this vaccine right now. We haven't seen it in Philadelphia, but since the Pfizer product was launched last week, I think there've been a half a dozen allergic reactions reported in the United States. All of them were handled promptly, and there were no deaths or anything serious as consequences from these. But the current thinking is that there is some allergen in this mRNA product. It's not the vaccine itself, but it's probably some molecule that is part of the, I'll say, the packaging of the vaccine. So they're trying to figure that out, and potentially when they answer that, they'll be able to remove it, and this may not be an ongoing issue. But what we are doing now, and this is the CDC standard procedures about this, is we screen every person we're about to vaccinate for a history of severe allergy or anaphylaxis to an injectable product, such as a medication, a vaccine, or any other kind of treatment that's injectable. Now, they do know that the allergies to food are not relevant to this. You can be allergic to food and still be vaccinated. Allergies to environmental things such as bee stings or some other bug or plant, those also don't seem to have any interaction with the vaccine allergy. So what the process is that we're doing in the clinic is we ask everybody about a history of severe allergy. If the severe allergy is to food or to a environmental allergen, we go ahead and vaccinate them, but we observe them in the clinic for 30 minutes after the vaccine just to make sure that there isn't any reaction that could occur in a delayed fashion. If the person has a significant allergy to a medical product that they were injected with, so they had an injectable vaccine, injectable medication, or any injectable treatment, and they had a serious allergic reaction to it, we consider that an absolute contraindication to vaccine, and we will not do them in our clinics. Now, I think in theories, you could do those in a medical setting where you have the capacity to respond if there were an emergency, but that should not be the case in pharmacies or in most of our walk-in clinics. So if you have that level of contraindication, then I think the only thing that you can do is continue to socially distance and mask and restrict your exposure to patients who could have COVID. And then my guess is that some of these newer vaccines that will be released in the spring will not have this contraindication that's related to allergies to medications.
Thank you, Dr. Johnson. There is a comment in here about Avena Healthcare having staff available to assist facilities with vaccine administration and a direct number to call. Then the next question is, will all DBH contracted providers be required to receive the vaccine? And I believe that was covered in the FAQs, but Dr. Johnson, would you want to respond to that?
So the city does not have any mandate for this vaccine. It is completely optional by choice. It's recommended, but it is not mandatory. It is possible in the future that employers could make this a mandatory vaccine. And I don't know too much about your behavioral health network and whether you see vaccine mandates, but some of the hospitals in Philadelphia, if not most of them, I'd say more than maybe about 75% of our hospitals have a flu vaccine as mandatory. And it's completely legal for them to do that. They are a private employer. They can pass those kinds of requirements. And I would expect that in a year, you will see COVID-19 vaccine as a mandatory vaccine for people in some occupational settings. But there are too many shortages now. There's too little known about the vaccine. Remember, it's not got official FDA approval yet. It's got this emergency use authorization from the FDA. So you could not mandate any vaccine until it had full approval. So I think we're significantly long time away from that. And I don't expect the city will ever mandate it for city employees or city affiliated employees.
Questions are coming hard and fast now, which is good.
Yes, I know. There are a lot of you on the line, and I'll stick it out till 12. I'm actually sitting in the vaccine clinic as we speak, so that background noise you may be hearing. But go ahead.
Well, really appreciate you making the time and at short notice. Sure. Can this information be available to us for us to print out? I think they already posted the FAQs in the chat, and some of what you've covered, some of what you said references that. But we will be sharing the video as Kate mentioned earlier. Question about what about admin, non-public facing staff? When will they be eligible?
I would say that they're going to be eligible. Oh, you brought that up. I would say in phase 2, so that we will be doing what we're calling essential non-public facing workforce. So I would say they're going to come up in phase 2. After we get through all of the people that have continuous exposure to this virus, we will be doing essential workforce who aren't exposed to the virus, but it's in our best interest to keep them on the job, if that's making sense to you. I mean, so there's some people we know that just have to work even though they're not exposed, and we want to make sure that they're healthy and don't get this infection and have to take time off. So I would see the non-public facing administrative type staff come up around phase 2. Now,
Okay.
I mean, when that's going to be, I have trouble even guessing, but I would say probably not before March. And that might even be pushing it as an early date.
Okay. All right, good. What documentation do our staff need to make an appointment?
Yeah, I think when we've spoken with the pharmacies about this, we and the urgent care that we're going to partner with for this, they're going to create, I think, what's called a voucher system. And so when an invite goes to, let's say, facility A and say, please invite your staff to be immunized at one of these pharmacies, and there'll probably be a list of them, it will be accompanied by, I'm going to call it a ticket for want of another thing. It'll be some kind of voucher, some kind of ticket that is assigned to that person that sort of validates that they're eligible for vaccine. So we're going to try not to make this too complicated. And I believe the pharmacies want to sort of create their own voucher for doing this. And we probably will look to the employer for handing out the vouchers and speaking for their staff, kind of certifying that they are employed there. And that's, I believe, how this will be handled.
Got it. Okay. Thank you. Can you repeat how residential substance use treatment programs, patient and staff fall in the phasing schedule? Is there a difference for priority of adult residential patients and adolescent patients?
Okay, so the staff, I think that's the one we were talking about, is phase 1A. If you're patient facing, public facing, you're considered a healthcare worker and you're going to be covered in phase 1A, but of course we have to get the vaccine into the city and into the sites who can vaccinate you. That's that group. Now the patients themselves, if they're residential, if you're in a residential facility, then there will be staff coming in to vaccinate staff in phase 1C, which is where we're doing congregate settings. That's when we start to work in the prisons. We are starting to work in the homeless shelters, and we will be doing the residential drug and alcohol. So that's for residential. For the facilities that are ambulatory or see regular clients, then the patients themselves are not going to have any kind of priority access to vaccine based on a drug and alcohol or a psychiatric diagnosis. That does not qualify them as having an underlying medical condition that puts them at risk of COVID. So they basically have to wait until their number is called based on their, I'll just say their overall health. So for example, if you have a client that has type 2 diabetes, they are going to fall into a quicker, they're going to be eligible for a higher priority vaccination than a healthy 20-year-old. So this gets to be somewhat complicated. Matter of fact, it's changing all of the time. Just changed this past weekend. The CDC just changed their priority strategy. So I would say that for your ambulatory clients, the priority is not going to be based on anything related to drug and alcohol or behavioral health or psych. It's going to be related to their age and their medical conditions. And I think that's not something we're going to put the DBHIDS providers in the middle of. I don't think you're going to be the one that has to determine when they're referred for vaccine. That will fall more to their medical providers. I do want to make a point about adolescents and children. This vaccine, again, it's not fully FDA approved. It's under an emergency use authorization from the FDA. The vaccine, the Pfizer vaccine has emergency use authorization for age 16 and up. The Mrna product is 18 and up. So there are no indications right now or even eligibility to administer this to children. And I think it'll be probably a couple of months before we see any indications that involve children. I can't tell you any more about that. I know that they're doing the studies, and I believe it's just as safe in children as it is in adults, but it's the priorities have been, of course, working with adults and with seniors because they're the ones who die from this infection. There may be some pressures to get children vaccinated just to help with getting the schools back operational, but I have not seen that on a timeline. So the only thing I know is if someone 16 or over could receive the Pfizer vaccine, if they were, example, in a congregate setting, we might include them in that, but there will be very little vaccination of anyone. There will be no vaccination of people below 16 until we get another product available.
Excellent. We have 10 minutes and 11 questions. So what I'll do is I will skip any questions that have been answered already. There is a question here about the requirement for providers who want to be a vaccine site. If that provider does not have an EMR, is there a way to do manual reporting to Filovax?
So they did create a spreadsheet, an Excel spreadsheet, where you can type in the name of the person and the date of birth and all the information that's required. So it is possible that you could enroll to be a direct provider of vaccine. And the information about that is on that website that it's on the last slide, and it's the one that has, I believe, Filovax somewhere in the title. So yes, you could probably apply to do that. I can tell you they're so busy now enrolling some providers. I don't think you will get too much attention for the next few weeks. So I would probably wait a couple of weeks before you try to enroll to be a direct provider.
Absolutely. We're not going to be able to get to all the questions. There are questions within the chat box. There are also questions within the Q&A. And we haven't even finished the ones in the chat box. So rest assured, what we will do is gather these questions, all these, both what's in the Q&A and what's in the chat box, and make sure that they're responses and get them back out to the group. Let me see. We've talked about outpatient providers being mandated. That's been answered already. Should you prefer one vaccine over another? Are you able to choose?
Right now, you will not be able to choose. And I'm thinking that most of your staff are going to end up with a Moderna vaccine, if you wanted to like read ahead about it. And the reason I say that, Moderna is the product that does not require ultra cold storage, and most of the pharmacies don't have ultra cold. So we will probably launch that program only with Moderna vaccine. So I'm going to guess that's what you are going to have available to you. By the way, if you start your first dose with Moderna, you must complete your second dose with the same product. They're not mix and match, at least not yet. You must complete your series with whatever your first dose is. Right now, it looks like most of the Pfizer or the ultra cold product is going to be going to hospitals and big centers because they have the special freezers, and that most of the Moderna is going to be going to our pharmacies and our clinic site. So I would guess your staff are going to get Moderna.
Okay. When we receive notification that of the vaccine being available, will the employee ID badge be sufficient proof of employment?
Yeah, I think that's the one where we're going to ask the employer to give the ticket or the some kind of voucher. So some of that still has to get worked out, but we're not going to make you jump through a lot of hoops. You'll have to make an appointment. You'll identify the site you want to go to. You will have to make an appointment, and you will have to sort of show some proof, whatever that is, be it a voucher or your ID. We won't make it too complicated.
Okay. How will facilities be notified? We have there is a facility that has an outpatient SUD program that also serves as a COVID testing site.
Mm-hmm. So if they are a COVID testing site and actually doing active COVID testing, they should have already received an invitation to come in and be vaccinated. So I actually would appreciate if you send me the name of the site that's doing COVID testing, and I will make sure that we get them in the queue to do them as a priority. So if I could have that pass through your hands, Dr. Shoyinka.
Sure.
Me that information. I will just make sure that the COVID test sites are handled. By the way, and I don't know totally who's on this call, but we only are dealing with Philadelphia. I don't know anything about the plans for facilities that are outside of the Philadelphia borders. The amount of vaccine we get is based on the size of our population. So we are not trying to recruit people from the suburbs to come in and be vaccinated in our facilities. This is a Philadelphia only program.
Okay, got it. Are there any prescription medications contraindicated with these vaccines?
Excellent question, and there are not.
Okay, good. And do you have immunity after the first dose, or do you need to have both injections to have immunity?
So that's interesting. There's been a lot of talk about whether we should just be giving everyone one dose because there's so many shortages. One dose probably gives about, I'll say 50% protection, which is not great. So I won't say it's zero. You really need 2 doses for good protection, but 1 dose only does give you some. So I recommend the 2 doses, but if you only get 1, it's better than nothing.
It's an interesting question. Okay, thank you. There's a question here about what about residents of the suburbs who work in behavioral health in Philadelphia?
I don't know the answer to that.
Is this a yearly vaccine?
Is this a yearly vaccine? not currently, but we don't know the answer. We don't know how long immunity lasts. So I don't think we have to look at this clearly as the annual vaccine, but it could possibly turn into that. So I think we just have to watch and see what happens.
Okay. There's a question here in the Q&A about that there have been some incidents of Bell's palsy. Is there any information about this?
Right. So that's this, and that one is specifically for the Mrna vaccine. Bell's palsy, in case you don't know, is a paralysis of half of the lower half of one side of the face, where the nerves just sort of stop working and you get a bit of a facial droop. Bell's palsy is usually fully reversible, and it's one of the common symptoms that you see with Lyme disease. So Bell's palsy was seen in the Mrna trial. We didn't see any of it in the Pfizer study. In the Mrna trial, there were 3 cases of Bell's palsy in people who got the vaccine, and there was 1 case in the placebo group. So it's a little bit strange. We don't usually see Bell's palsy in vaccine trials. So I really can't give you too much insight about that. The fact that there was a case though in the placebo group thinks that maybe there's some environmental background. Maybe these studies were being done in areas where Lyme disease were prevalent. What we're really picking up were a couple of Lyme cases occurring. So I'm sorry, I don't have a deep or a firm knowledge of what the significance of the Bell's palsy is, but it is reversible. And most of these are fairly mild. I've seen Bell's palsy cases go away within a couple of hours. There'll be a transient sort of droop on the face and then it goes away quickly. Some others may last a week or 2. So it is, it's a significant reaction, but it is a reversible one. And I think it's not clearly being stated as related to the vaccine now, because there was a case in the placebo group. So they're not explaining exactly what's going on. So I would just say more information should follow on that, and you can kind of keep your eyes on the literature to see what more we learn in coming weeks.
Thank you, Dr. Johnson. We are at time now. We have 1 minute and we have 16 unanswered questions in the chat box. Some of them are, a couple of them were already answered. They were posted in both the chat and the Q&A. But we're just there, and they're excellent questions. We just can't get to them right now. So as I said, we will gather this information, these questions, and provide a response working with Dr. Johnson and her team. Dr. Johnson, as we wrap, do you have any concluding comments?
No, I just appreciate your support, and I appreciate the fact that you understand how hard it is to meet all the personal demands or requests that people have for information. And, I'll let you know everything I know as fast as I know it, but things change very, very fast. And we'll just try to stay in touch with you.
Thank you. And thank you to all our attendees and everybody who's joined the call today. My apologies for the technical issues we had at the beginning. And appreciate everybody's excellent questions, very thoughtful questions. We will gather these, get responses out to you. Kate has just posted the email address to which you can share additional questions or reach out if you have anything else we need any clarification with. We will collaborate with PDPH on responding to those. And I wish everybody a safe and healthy holiday season, and we'll be in touch. Thank you.
Hi, everyone.
And thank you to Kate Fox for setting this up. This is excellent.